Thank you, Francesca. Hello to everybody on site and online. I'm going to talk about the cardiovascular manifestations of vascular EDS and the follow-up of patients with this condition. I don't have any conflicts of interest to declare in regards with this presentation. Just a little disclaimer, the presentation here is a global overview on how to monitor and manage patients. There is no consensus on how these patients should be followed or monitored. So this is mainly clinical practice, but many centers do use that clinical practice. And of course, it is not destined to replace the advice of your local expert who knows your medical history and file in the care of your problems. Just a little reminder about vascular Ehlers-Danlos syndrome. I'm not going to redo the whole history, just to tell you that it is an autosomal dominant disease characterized by a dominant negative effect for a majority of variants, namely the glycine substitutions within the triple helix and the splice site variants not leading to haploinsufficiency. And these two types of mutations represent approximately 80% of patients. The remaining almost 20% would be variants leading to haploinsufficiency, which do have a lesser reduction of type 3 collagen and are more and more evidence to have a less severe course of disease. We'll get a little insight into this later. Of course, the diagnosis of vascular EDS imperatively requires the identification of a pathogenic variant within COL3A1 gene. Thus, is very important. Natural history of vascular EDS has been first reported in this form by Melanie Pepin from Peter Byers' group, and remarkably all the other cohorts published in the world found a similar curve of onset of complications with 1/4 of patients having a first event by the age of 20 years and over 80% becoming symptomatic by the age of 40 years. Of course, the first most predominant complication of this condition are arterial accidents, followed by digestive complications, the most frequent of which is bowel perforation. There are factors that influence these outcomes. Of course, the gender, with a more severe course of disease in men. The ascertainment status, as you can see here on the illustration on the right, that relatives seem to have a less severe outcome than the index patients. Index patient being the patient being referred for the first in the family for diagnosis, obviously because he is symptomatic. As seen before, the clinical expression of vascular EDS is age dependent, and typically, or as initially reported during childhood, the patients are free of events. We'll see in a few minutes if that is true or to what extent that is true. What we have observed is that organ complications may be triggered by intervention for another disease that has nothing to do with vascular EDS. During the teenage years, events start to occur. There's a nice paper from Shireen about pneumothorax that often is the first event in teenage boys, and that may lead to secondary arterial complications. Sigmoid colon rupture may also occur, and I'm sorry, I'm going too fast. During adult life, the disease is considered clinically active. Arterial accidents are the most common characteristic manifestation of vascular Ehlers-Danlos syndrome, and they occur at a median time interval of 1.3 to 1.6 events per 5 years. So that's remarkably similar between the French cohort and the British cohort, from which these numbers have been taken. And the first most frequent arterial accident is a dissection with 71%, followed by aneurysm formation. Ruptures are relatively rare with 6%. And a not frequent complication is the spontaneous direct sinus cavernous fistula that occurs almost exclusively in women. The distribution of arterial defects is very wide because it's a disease of medium-sized arteries, and there are many medium-sized arteries within the body. The main locations where these happen are the head and neck, it's the abdominal aorta and its branches, and the iliac arteries, and in a less frequent manner, peripheral arteries. So, as a patient, when are you to suspect an arterial accident? As represented here, the red dots indicate that usually there is pain associated with the arterial accident that is happening. For thoracic aorta, it would be acute chest pain. For acute abdominal pain, you should suspect dissection or rupture of an intra-abdominal artery. For the neck, carotid arteries or vertebral arteries frequently are not there. There's no pain when these dissections happen, so you should be aware for signs of stroke. So apparently this changes automatically. For sinus cavernous fistula, typically you would have some brie tinnitus, but not pain. Eventually exophthalmy with a little pain. Dissections that can be painful, not little pain. In the forearms or in the legs, dissections are usually painful, so any pain at these levels are a warning sign. So I wanted to show you this to illustrate a little bit the influence of genetics on outcomes, but this is not going to work. So I resumed the information on the table in a little bit more readable way. And so there is a significant difference in the cause of disease between patients with dominant negative variants and patients with variants leading to haploinsufficiency. And as we identified in one of our publications, is that this translates into a later age of molecular diagnosis, in a later onset of arterial complications, in a lower mortality and a higher lifespan. And there's also a difference in arterial disease. There is similar aortic involvement when we adjust patients to age, but patients with dominant negative variants have more frequently dissections of the head and neck arteries and renal artery dissections. So how are these arterial complications treated? Majority of these are treated medically, and as Shireen described yesterday, there are some protocols to control the blood pressure, heart rate, there's anxiolysis, part of it, pain control, and of course limitation of fluid overload and inotropic agents. Sometimes the prescription of antiplatelet agents or anticoagulants is being discussed, but has to be discussed carefully. And I think we can all agree that thrombolysis in these patients should be avoided. In the recent years, there has been an important development in the therapy of arterial accidents in the surgical field and in the endovascular field, and a lot of these defects, notably ruptures, are accessible to embolization during safe procedures, ideally with highly trained radiologists or surgeons. And these procedures very often have a good outcome and are a good therapeutic option, especially in case of arterial rupture. For reconstructive surgery, it is done at best in elective situations rather than emergency, where ligation of arteries might be sometimes preferable. We come now to the principles of patient monitoring. Often we do an initial evaluation of the arterial tree, and this gives us the possibility to have a baseline look of what arteries, or the state of the arteries, and eventually integrate them in an arterial progression score. And what do we monitor thereafter? Clinically silent patients, of course, and we do monitor arterial beds, mainly at-risk arteries. That means medium-sized arteries in the aorta. The intervals of monitoring are being adapted to each patient, the type of mutation, the mode of ascertainment, and the type of mutation. This monitoring is associated with regular outpatient visits, visit intervals between 6 and 9 months. And these, in our practice, the monitoring periods range from 1.5 to 2 years. And I must say, with time, we're intending to enlarge these a little bit more, maybe even over 2 years for perfectly stable patients. It's important to say that the fact that you monitor arteries does not exclude the possibility for arterial accidents to happen at all. The other situations that require monitoring are, of course, during acute arterial accidents. That may seem logical, of course, by any necessary means to optimize the care of the patient. And thereafter, you would want to have some arterial surveillance of the dissection or accident that occurred, of the therapy you would have done to make sure that everything is okay. Any other event might also be a motive for monitoring. What is at risk is intensive care unit stays, surgery, or important blood loss with transfusion or prolonged hospital stays. So I think it would be advised to do at some time point a sort of monitoring. Pregnancy is, of course, an important event that needs some monitoring in the postpartum. There are other situations in which monitoring may be discussed that would be for us asymptomatic children of less than 13 years. We'll see the GAN standpoint in a few minutes. And asymptomatic teenagers, it is very likely justified and more persistently in male teenagers because of the increase of arterial accidents. The use of radiation, of course, should be avoided for both children and teenagers. The modalities of monitoring very quickly are CTA, MRA, duplex ultrasound, echocardiography, all these modalities having their advantages and disadvantages. It depends on every center what modalities you use and on which territories you would use them. Just a quick word on medical prevention of arterial complications. So drug use to prevent these arterial accidents. So there's only one clinical trial that has addressed this problem, and that used celiprolol at a daily dose of 400 milligrams. So due to limitations, methodological limitations, that it was necessary to conduct a confirmatory trial, and this trial is supposed to be actually recruiting in the United States, but I don't know exactly where that is at. Other medications of interest that have publicated data are bisoprolol alone or in combination with losartan in a recent observational study. Irbesartan, it's a trial, it's a medication we trialed in our center in a multi-center double-blinded trial on top of celiprolol, and the results are pending, so published very soon. We will have these, and there was enzastaurin a few months ago, but the trial is suspended by the company that owns the drug. Just a very quick word in less than 1 minute on venous disease and vascular EDS. Here are the different aspects of venous disease. I wanted to talk about varicose veins, following the patient testimony we had yesterday. So varicose veins are very prevalent in patients with vascular EDS, estimated at 37% versus 17% in the general population, and these are of early onset. 44% of patients before 20 years having, in this study, had very significant venous insufficiency. And one explanation for that could be the pathophysiology of varicose veins, meaning a downregulation of type 3 collagen and an upregulation of type 1 collagen. And since vascular EDS has a deficit of type 3 collagen, this could be one of the main causes of the high frequency of vascular veins. So these varicose veins can be a cause of hemosiderin deposits that are not very aesthetic, especially for young women. They can also be the cause of very apparent varicose veins, and that can cause swelling and pain. And this needs to be addressed for functional and for cutaneous protection. So the main treatment principles of these varicose veins is that the surgical vein stripping should be avoided because of the risk of rupture of the femoral and vein and artery. We had several examples of patients that had these complications without the diagnosis of vEDS having been known at the time of surgery. So endovascular therapy is preferred and it is effective, and it uses laser and radio frequency. And there's another minimally invasive surgery that is phlebectomy, and it is, in my experience, totally ineffective, because when you pull the vein you want to remove, it would simply tear and remain within the part you wanted to remove it from. So I think a better alternative to phlebectomy would be sclerotherapy, or foam sclerotherapy, with far better results in these patients. So this is the end of my presentation. I think the most important message for today would be that management of vascular EDS needs a multidisciplinary team that provides everything the patient needs, from emergency care to genetic testing of family, to clinical follow-up and arterial monitoring, and medical prevention of arterial complications. Thank you very much for your attention.